بسم الله الرحمن الرحيم. أهلا وسهلا بكم جميعا. من دواعي سروري وامتناني أن أقدم الأستاذ الدكتور علاء الأبراشي. الأستاذ الدكتور علاء صديق قديم لجمعيتنا. أول دعوة كانت له ب 95 ويشرفني تكون أول ورشة عمل وركشوب ألتراساوند اتعملت الأخ علاء الأبراشي وزميلنا الأستاذ الدكتور محمد ممتاز والأستاذ الدكتور عبد المجيد رمزي. ومن ذلك الوقت والأخ علاء ضيف عزيز على مؤتمراتنا، فأهلا وسهلا بك دائما أستاذ علاء. الدكتور علاء رئيس قسم الفيتا ميديسن بالقصر العيني، وله إسهامات عديدة في الألتراساوند وركشوب في مختلف الدول العربية، وهو مراجع لعدد كبير من المجلات العلمية. فأهلا وسهلا بك دكتور علاء، تفضل سيدي.
شكرا جزيلا. Good afternoon everybody. Dr. Ahmed, my dear friend, co-chairman, thanks very much. Again, I would like to thank Dr. Maher, Dr. Abir for their kind invitation. And I will going to present a topic is called color Doppler in the first trimester. Just I want to correct, I was the director of the fetal medicine unit, Cairo University, but everything's changing, and the young generation now, Dr. Mona, is the chairman of the unit. So I'm also happy that we have very nice and good and dedicated generations that take over. Color Doppler in the first trimester. Before I go in the color Doppler in the first trimester, I want to remind you that I think the first question will be after this lecture is it safe to do color Doppler in the first trimester? And this is a publication of the ISOC, and it was updated from 2008 and 2013, and says that yes, you can use color Doppler, however you have to follow the terms and the conditions. One of them, or the most important, is your TI, thermal index, should be less than 1, and your exposure should not exceed 5 minutes. So you have to be trained very carefully when you use the color Doppler in the first trimester. You know, the color Doppler brings high energy, and that's why they are very cautious about that. Okay, we know, of course, in the early pregnancy, we can document the presence of a normal pregnancy, location, everything, and we can document also the living state. I mean, the color Doppler will demonstrate the heart. Of course, you can use the M mode, you can use the pulsed Doppler. However, it's much easier if you use the normal Doppler. And this could also document the missed abortion. Many cases is referred to just document, to confirm that this is a case of a missed abortion. Sometimes we use the ectopic pregnancy diagnosis as well as to demonstrate a viable trophoblast that needs surgery, that needs treatment. Gestational trophoblastic disease, the persistent one, is showing vascularity behind the endometrium, as I'm going to show you. So this is, first of all, the normal pregnancy, and you can demonstrate the pulsations starting from 5 weeks transvaginal, 6 weeks transabdominal. It's very clear and obvious, and you don't have to have too much energy. Just 1 second, it will give you the documentation of a fetal heart. In ectopic pregnancy, you all know that we have the classical criteria, that we have amenorrhea or change in the menstruation together with a adnexal mass, adnexal cyst, and this adnexal cyst usually it is beside or juxta to the ovary. However, you can demonstrate also the pulsations, either the pulsations around the ectopic, which is called ring of fire, which is different from the corpus luteum, which is inside the ovary. And sometimes you are lucky enough that you can see the pulsations of the embryo itself inside the ectopic gestational sac. This is the ring of fire. It should be beside the ovary, not inside the ovary, to differentiate it from the corpus luteum. In gestational trophoblastic disease, you know that the trophoblast first proliferation is characteristic to have no vascularity. So the classical example of the vesicular mole or retiform mole, you should not see vascularity. However, later on, if you have a persistent trophoblastic disease, you will find that the vascularity will be spreading within the endometrium or around the subendometrial, and this may indicate that there will be persistent trophoblastic disease. Of course, you have to correlate it with the beta HCG, as well as chemotherapy also will induce some high vascularity in the endometrium. So this will help you in this part. The cesarean section scar, you all that the criteria that demonstrates the cesarean section scar, and most of the editors or the authors that have explained the cesarean section scar, Stimmertrich is one of them. And it has said that it is a precursor of morbidly adherent placenta, especially if you demonstrate some vascularity in the part related to the anterior wall. And this is the RCOG criteria for diagnosing cesarean section scar, and you can find that the last part is the evidence of prominent circulation on Doppler examination at the area which represents the cesarean section scar. So it's also important in documenting the cesarean section scar. Now we come at the 12 to 13 weeks in which we can use it for uterine artery screening, ductus venosus, tricuspid regurg, fetal heart rate and fetal anatomy, heart and umbilical arteries. And I know that my dear friend, Dr. Mona, have elaborated very nicely in the morning what is the screening for the uterine artery concerning the preeclampsia, so I'm going to pass by. Just I want to give like a conclusion of myself that when we in the 2000s, we started to demonstrate some important relation between the high resistance uterine artery and the preeclampsia, which is a type of preeclampsia which we call it preterm preeclampsia. What is the preterm preeclampsia? It is a type of preeclampsia which comes before 34 weeks. And this is the dependent on placental migration, I mean trophoblastic migration. And this may be related definitely to the vasculature of the placenta. When we find the high PI in these cases, we can predict the occurrence of such type of the disease. And then we shifted from the 2000 until 2010 that we had a clear idea about can we implement some sort of therapy in order to ameliorate or postpone or even prevent the type of severe preeclampsia that occurs before 34 weeks. And it happened that in a very nice publications, I know that Mona have presented this, we can say that this is one of the first systematic review that was done in early administration of low-dose aspirin, prevention of preterm and term. It was at that time definition of what we call preterm and term preeclampsia. Term preeclampsia is after 34 and is usually not dependent on the uterine artery. And in this systematic review, they have concluded that low-dose aspirin administered at or before 16 weeks. So the timing or the roof of giving aspirin is around 16 weeks, not after that. It reduced the risk of preterm, but not the term preeclampsia. And additionally, from this point, they have multi publications for the role of aspirin in the prevention of preeclampsia and fetal growth restriction, systematic review. And also it concluded that the preeclampsia and fetal growth restriction using aspirin is associated with a dose dependent. What we meant by dose dependent, we have changed the dose between, it was usually 75 or 80 milligram, now we change it to 150 milligram. Of course, you are going now to use all the package. It is the same software that you are going to apply. And you know, firstly, the PI of the uterine artery, and then you will add the mean blood pressure, the body mass index, as well as some biochemical markers if you want to have it. So ultimately, after some time, we got out the ASPER trial, which is a very large trial performing the screening for preterm preeclampsia. This is the largest trial that was done. As you see, it is including 26,000 cases from different centers. And they had a protocol of that giving placebo or not giving aspirin. And finally, they also have the same conclusion as I told you. It is a dose dependent and it can reduce it by a number of 60%. What about the reference range? This was updated in 2023, the atrial arterial state. So you have to know the atrial arterial state in order to put it in the, is it more than 95th centile or not? And this, you can find it in the internet, whatever. You can see it here, and you can just demonstrate when are you scanning the atrial artery. For example, at 13 weeks, you will check for the 95th centile, and you will put your evidence based on these reference ranges. The role of low molecular weight heparin actually is very diverse. And when you ask somebody of the eminent fetal medicine specialists about the low molecular weight, he said that there is no clear evidence that we can use low molecular weight in these cases. However, it could be individualized. In other way, if you have the PI, which is very high, and then you administer aspirin, and then you repeat the examination between 16 and 18 weeks, and you found there is no improvement. In this case, some of the cases may benefit really from adding low molecular weight heparin. And this is a systematic review published in the American Journal, and you can see here what is the results. The results of 15 studies in high-risk women, treatment with low molecular weight heparin was associated with a reduction in the development of preeclampsia, small for gestational age, and this reduction was stronger if low molecular weight heparin was started before 16 weeks. So it could have, you will find a lot of dilemma in recognizing a definite or a consensus about low molecular weight heparin. However, if you look for the publications, you'll find it could be of useful in some cases. Individualize your cases. You see, this is the last statement. However, there exists important clinical and statistical heterogeneity, and therefore these results merit confirmation in large, well-designed clinical trials. Now we come to the second item, which is the ductus spinosus. This is a very nice vessel, very small one, which is 2 centimeters long, and it is connecting the umbilical vein with the right atrium directly through the inferior vena cava. Its waves are usually characteristic by an SDY wave, and the S represents the ventricular systole, D represents the ventricular or the early diastole, and late diastole, when we have some contraction from the atrium, it produces the A wave. So we actually look for the A wave because it represents the atrial contraction. And you know, any forcible atrial contraction means that we have an abnormality in the compliance of the heart. There's something abnormal in the heart. And in late pregnancy, it documents or point out the presence of heart failure or the ongoing heart failure. So that's why the ductus spinosus is very important, and its relation to the first trimester, it remains as an increasing sensitivity in detecting some of the cases of Down syndrome, as well as may show underlying heart anomaly. And sometimes it's related to the monochorionic diamniotic pregnancy in the prediction of TTS. So this is the classical example of the ductus spinosus. How can we get it? We get the mid-sagittal plane, which is the golden position for the 13 week, and then you immediately put the color Doppler with some adjustments. You know that the ductus have a very high flow. So when it has the high flow, always you will find the aliasing phenomena in the part that you are going to see. So the part aliasing, you will putting the pulse gate and obtaining the waves, and then you can analyze these waves. This is the protocol of assessment that you should follow, the same like you follow in the nuchal translucency. You can have them, read them, and perfectly follow each item of these, especially when you are having the sample volume should be small, and of course the insulating angle should be as 0 or 20, and finally the sweep wave. When you find the waves are crowded, you have to separate the waves as much as you can in order to analyze it very well. So this is the typical pattern in the mid-sagittal plane. You find this is the aliasing part of the ductus. This is the classical wave, And one of the eminent leaders in the field of ultrasound gynecology, Timmerman was behind something called the PI of the ductus venosus. This PI could be detected by the simple auto calculation, and you find that it is have as S minus A over the mean, and it could give you some numbers. So we are now changing, is it a qualitative or quantitative method of evaluating the ductus? If you take it qualitative, then the positive A wave. If you or negative or reverse, it's abnormal. If you take it quantitative, then you have to respond to this references according to the 95th centile. So use whatever you like in these parts. Again, this is the ductus. You see here, this is what I told you about the sweeping wave. It should not be like this, crowded. It should be giving spaces so you can measure it well. And this is the qualitative way of evaluating negative E wave or reversed E wave. So what's the relation of the ductus? The ductus, as I told you, negative E wave will give you some increasing sensitivity in detecting Down syndrome as a part of soft markers, underlying heart anomalies, and other anomalies like the monochorionic in the prediction of TTS. See, the paper started 2010 as describing the relation between the ductus and other findings, like the major heart anomaly. In this case, you find NT, wide NT with a negative ductus, increase the likelihood ratio for having a major heart anomaly. I like very much this one, which is the contribution of the ductus. This was published, I think, in 2010. Demonstrate that in fetuses with major cardiac defects, abnormal flow in the ductus is observed, not only in those with increased NT, but also in those with a normal NT. So whenever you find a negative E wave, it is a must that you have to go for the heart and evaluate the heart. This is a negative E wave with Down syndrome. This was a high PIV in cystic hygroma. And this is, again, classical aneuploidy with a negative E wave and so on. Let's have this is a very rare case of absent ductus, when you don't find the ductus. And this was, the hepatic portion is replacing the part, it's reaching the umbilical vein. Reaching the inferior vena cava. So it also could be related to the ducts, but this is extremely rare cases. Third item is the tricuspid regurg, and the tricuspid regurg carries the same influence and the same meaning of the underlying either heart anomaly or increasing sensitivity of detecting aneuploidy, mainly Down syndrome. And how can we do this? You take the mid-sagittal plane of the fetus, and then you rotate your hand 90 degrees. Then you will find the heart in the fourth chamber. You get the fourth chamber, of course, in the area and the time of fetal quiescence. Then you understand where is left and right. The left is towards the spine. So you take the other side, then you will identify the tricuspid, you put the gate as wide as possible, and then you start your having the waves. This also is the protocol of assessment with the magnification and everything. And again, the sweep wave and so on. What is the picture? This is the classical picture with the magnification. We are going to comment on the regurg between each cardiac cycle. And now it's almost 60 or 65 centimeters per second that could be recognized as tricuspid regurg. This is the application, as I told you, also in the markers for Down, as well as for the heart anomaly. And this was actually proved by Egan et al. Group working with Cyprus in 2006. This was the publication, fetal heart rate in chromosomally abnormal. Does the fetal heart rate have effect in the also sensitivity? It is not very well used. However, it was reported that in fetal heart rate, in trisomy 21 and trisomy 13 and Turner syndrome are associated with fetal tachycardia. while in trisomy 18 and triploidy are associated with fetal bradycardia. So sometimes it could be benefiting inclusion of fetal heart rate in the first trimester screening by combination of maternal age and fetal nuchal is unlikely to provide useful information in sensitivity. So we cannot say that 100%, but it is one of the elements that could be used. What else? The fetal heart. The audience have noticed yesterday that George, my dear friend, have explained how can we use the color Doppler in the 13 weeks. Actually, it's very helpful because the heart is at that time is small, and the signs that you can demonstrate in the heart by color Doppler is magnificent, and it gives you a very important idea about the heart. And actually, the ESOC guidelines, the recent ESOC guidelines recommend that you can use color Doppler in demonstration of fourth chamber as well as the V-shaped and so on. I am going to show you, this is some of the pictures presented in the most recent ESOC guidelines for the heart examination. Again, how to do it, how to examine the heart in the 13-week. You start with the mid-sagittal, rotate your hand 90 degrees, and then concentrate of having a fourth chamber. Okay, I'm just comparing to you what is the picture of the fourth chamber in the adult and what is the picture in the, you can see in the 13-week scan. It's identical, however, you just, the perception should change, that you're having a very small one instead of the large one. And this is a classical example of the situs of the heart as well as the aortic outflow in the 13-week scan transabdominal. And also, actually, this is the 5-chamber view. Okay, this is if you don't even not using the color Doppler. All these are very important pictures. However, I want to concentrate on the color Doppler for evaluation. Before it, you have to read this paper, 2014. It was a very nice publication from Palermo, Italy. And it was published in the Prenatal Diagnosis. Transabdominal ultrasound was performed on 4,800 singleton pregnant ladies at 11-14 weeks to visualize the visceral side, the fourth chamber, and the outflow. What they use, actually, they use the color Doppler in the manner of this. You can use the evaluation of the fourth chamber clearly, and when you find the fourth chamber, you will find also at the atrioventricular junction, you will find a notch in order not to have it like a canal. And this is the example, with the addition of the very important outflow tract. In the outflow tract, how it could be visualized, it is visualized in what we call the V-shaped. However, also an important sign, you look here, this is the adult heart, and you find that the aorta and the pulmonary are crossing each other inside the heart, making what we call X sign. This is a very important one. You look at here, these are the ventricular system, and this is the X sign. So X sign is one of the very important landmarks if using the color Doppler. You can use it here very nicely. This is the crossing of the vessels inside the heart, and this is the miniature of the video. Of course, there is also a Y sign. This one is very important, extremely important. They call it the V-shape. When you see the V-shape, it is the ductus arteriosus ending into the aorta, and it should have same color directed to the spine towards the left side. Imagine any of the conotruncal anomalies, whatever you mention, you're not going to have this V-shaped, whatever. Just mention any type of conotruncal anomalies, outflow tract, it will not give you the V-shaped. So identification of the V-shaped is extremely important and also easy. So you can have the fourth chamber filling, you can have the X sign, and then the V sign. Putting them together, you will have a very conclusive evidence that at least you don't have major heart anomalies in this case at the time of 13 weeks. So again, you can repeat it many times and you can see the same finding. Actually, I have remind George that we have a publication from our center. It's a fetal heart examination by the time of 13 weeks, 5 years prospective study. This was published in 2019. And Mona was the second name, as you see, because we had actually 3 or 4 theses that we had to do heart examination together with everything, and these are our conclusions. We had a success rate in when we've examined the heart as the late of the spectrum, like after 70 millimeters until 85. And when the other publications came in 2022, you see here, this is the first trimester ultrasound detection of fetal heart anomalies, systematic review and meta-analysis. And all of them included our paper in order to just demonstrate that it's one of the very important papers. There are no papers now published about the first trimester heart examination without including any quotation from our part. I think this was the last one done by Simon from Australia, an important man in the ISOG. Congenital heart anomalies in the first trimester from screening to diagnosis. And here is our publication was referenced as 20. And they have said an important, do we have time? No? 1 minute, okay, let's have. So this is the heart. I am going to pass the heart. I think I have only 2 or 3 important applications. Now, one of them is aberrant right subclavian. In the aberrant right subclavian, this is one of the soft markers which can demonstrate also Down syndrome. How can we examine it at the time of 13 weeks? This is the way the V-shaped will show a pulsating vessel towards the ductus venosus, which ending into the aorta, and this should be pulsating in order to demonstrate that this is the aberrant right subclavian artery coming from the right side to the left side. And also, this is a very important one. As you see, it is the aortic arch. It's related to the 22 deletion chromosome, P11, which is either part of the DiGeorge syndrome or others. So it's very important to demonstrate the U-shaped instead of the V-shaped, as well as the aberrant right subclavian. What else can we see? We can see the umbilical arteries on both sides of the bladder, and this demonstrates that we don't have a single umbilical artery. But if you are in doubt, you have to do transvaginal because sometimes it is not very obvious. And of course, it carries the protocol of having a single umbilical artery. What are you going to do? Exclude chromosomal, then anomalies, and then you follow up the pregnancy. And this is the classical one. The last one is the omphalocele. Omphalocele also is extremely important. You can diagnose it after 11 weeks, after the end of the physiological hernia, and the size of which may give you a hint about the association of aneuploidy. If the smaller is more attached or more related to the aneuploidy than the other. You can see here, this is the umbilical artery. It is part of the bulging pence of the anterior abdominal wall. So finally, in conclusion, we can have the color Doppler in early viability, abnormal pregnancy, uterine artery, ductus, tricuspid regurg, heart assessment with Doppler are the main application of color Doppler, as well as some of the fetal anatomy, as I have mentioned. And this is a very nice illustration of the last thing, which is, this is the crocodile. And the crocodile is the medicine, the god of medicine in the old Egyptians. It's called Sobek. And you can see here, this is the pharaoh. And this is a very example of the very small embryo inside the amniotic sac. You see the serrated one inside the amniotic sac. And this is present in the Dandara Museum. And I think this was the beginning of ultrasound. Thank you very much.
Thank you very much, Dr. Ada, for this nice presentation. Any questions, audience? Any questions? Is the color Doppler harmful for the baby for early stage of labor, of pregnancy? Is it safe?
Yes, the first slide I put demonstrates that it is safe so long as you are using the terms and conditions. What are the terms and conditions? Your TI should be less than 1, and the time of exposure should be less than 5 minutes, which is too much if you are going to analyze any of one I have said. So it is safe in the safe hands. if you are using it properly.
Thank you.
Okay, thank you,
you.
Dr. Ala.
Thank you, Doctor, for amazing lectures. I have two questions. First question, is there is a difference between the M mode and pulse Doppler in detecting fetal heart when placed over the heart? The second question is there is any harm to the fetus when using the pulse Doppler during the first trimester? Thank you.
Okay, thank you very much. As I told you, the question is the same. What is the safety of color Doppler in the first trimester? Again, I repeat, according to the guidelines, it's not my guidelines. The TI should be less than 1. Exposure time should be less than 5 minutes. Should be purposeful. It's not saying the baby and let the mother and her aunt and the family demonstrate it. So this is closed situation. The second thing is what's the difference between M mode and pulse Doppler? Totally different. M mode is an emotion mode. It works with the undulation of the valves or undulation of the heart when it moves, and it gives you a picture which is silent, and you can use it definitely. Okay. But analyzing the color Doppler is much easier. You don't have to even use pulse it. You just put the color and that's it. It will take 1 second demonstrating either viable or non-viable. You cannot miss it. You cannot miss a viable without a, because if it is not viable, there is no color will produced. This is the principle of color Doppler, moving objects. If any of it is not moving, it will not produce either color or a pulse. Okay. Then if you want to use the pulse, it's okay to recommend how to document the heart rate. It takes seconds. Okay.
Shukran, Dr. Ala. Thank you very much. Our next speaker, Dr. Samir Al-Baba. He is Chief Pediatric Neurosurgery, President Orlando Health Children's Neuroscience Institute. He is co-director Fetal Surgery, Fetal Care Center, Orlando Health Women's Institute. He is a professor of neurosurgery and professor of surgery in University of Central Florida and the Florida State University. His talk about open hysterectomy versus fetoscopic in utero repair of myomeningeal seal. Dr. Samuel, please.
Thank you, Mr. Chairman. Good afternoon. And again, greatly honored to be here. Thanks to Dr. Mahaita, Dr. Annab, and the organizing committee for the excellent organization and for the invitation. The lecture earlier today was about this scientific evidence behind the open repair from myelomeningocele. And now we know what the technique is, we know the track record of safety, and now we know that this is now likely is heading towards the standard of care. Question is, which technique is going to be the future? The MOMS trial was performed using the open technique I showed you earlier. In my practice, I do the open technique, but fetoscopy is picking up. I'm going to start by saying that fetoscopy is the future, but we're not there yet, but we're heading in that direction. What is the standard of care today? And as I showed you earlier today, the standard of care is changing rapidly. The standard of care is to do the postnatal repair for myelomeningoceles. Myelomeningocele babies are born every single day worldwide, and the postnatal repair is the standard. We talked earlier today about the prenatal repair, the technique, and how it's done surgically. So we know that myelomeningocele is the most severe form. Open neural defect, we talked about the pathophysiology. We know that prenatal repair of fetal surgery or intrauterine repair, we know that it improves outcomes that we discussed earlier. And question is which approach is better. We discussed the open hysterotomy, and now we're talking about fetoscopy. Fetoscopy has two options: open after exteriorizing the uterus and doing the fetoscopy versus completely percutaneous fetoscopic repair. Just to remind you, a few slides from the last talk, the pathophysiology of hindbrain herniation, Arnold-Chiari type 2 malformation, the development of ventriculomegaly leading to hydrocephalus requiring shunting and treatment, all starts by the leakage of spinal fluid or CSF at the spinal bifida defect. And if we do the repair in utero before 26 weeks of gestation, this has been proven by the MOMS trial that doing the repair will lead to a reversal of the hindbrain herniation in almost all cases. And we discussed that the take-home message is it works, it helps the baby, not with bladder bowel dysfunction or control. It improves the motor function, lower extremities. It improves the cognitive function. It reduces the shunting rate from 80% down to 20 to 30% and reverses in most cases the Chiari malformation. What's the cost? The mother will go through 2 cesarean sections. There's a risk of 10% prematurity under 30 weeks of gestation. This is a recent article our team wrote about showing that how the standard of care in North America is changing rapidly. What is the rationale for prenatal repair? Reduction of hindbrain herniation, improving function, reducing shunts. Let's talk about fetoscopy. 2 options. You do it either the fetoscopy is by doing the repair while the fetus is not exposed. If you remember from the last talk, we showed that our open hysterotomy went from 10 to 7, now to 4 centimeters. And if you add all the holes you put to the uterus while doing the fetoscopy, sometimes with 3 ports, if you add them up, you end up actually with the same length of the hysterotomy. But what's the benefit of fetoscopy is that up to 50%, not more than 50%, can deliver vaginal. Most centers who do fetoscopy, the vaginal delivery is in the range of 30 to 40%, but not higher. So this is the open and this is fetoscopy. What does the literature tell us? The meta-analysis and all the literature review have showed us we have no evidence today that which technique can serve better. Actually, you cannot compare them. Why? This is a prospective randomized trial, has been done for over 20 years. We have pediatric or even young adult outcomes now, while we have fetoscopy, only developed in the last few years. We don't have long-term data. So we cannot compare them. But now there are ongoing studies trying to compare them prospectively. But what is the dark side of fetus surgery? We all celebrate fetus surgery. Pictures, parents are happy. But every once in a while, we deal with a mother who is sad about how she's 1 out of the 10. Out of 10 fetus surgeries we do, 1 of them will deliver under 30 weeks of gestation. And this is, we call it the dark side of fetus surgery. That if you deliver too early, under 30 weeks of gestation, you have a tiny risk of mortality, but you also have risk of prematurity-related complications. So the open repair, laparotomy, the hysterotomy was big, now it's getting smaller. We directly visualize the lesion, and we perform multi-layered closure like we showed you earlier. What's the positive about it? Well-established long-term outcomes and proven outcomes via prospective randomized trial. The risks, maternal morbidity, no question, uterine scar, a cesarean is required when we deliver the babies at 37 weeks. Preterm labor and premature rupture membranes is 45% of the cases. And all the mothers who go through fetus surgery, they sign consent for surgery, including delaying the future pregnancy for 2 years. Obviously, after you put the uterus through 2 cesarean sections, this uterus, you don't want it to labor again within the next 2 years. That's why all our mothers over the last 15 years who waited 2 years after the delivery of the fetus surgery baby, none of them had any complications. So we showed earlier in the last talk the technique. I will cut down the slides just to make sure that we do not be repetitive, but after the exposure of the uterus, we localize the placenta, and this is after the hysterotomy opening. This is one of the older cases when we used to do 7-centimeter hysterotomies, and we showed you earlier that we do the multi-layered closure. And we talked about the ACOG recommendation. What is fetoscopic repair? A smaller laparotomy. Again, you can do it by exteriorizing the uterus or by doing completely percutaneous, 2 to 3 trocars. You do carbon dioxide insufflation or amniotic fluid distension, and then you do the fetoscopic repair. In most centers, you as obstetricians and maternal fetal medicine specialists, you have much better experience than us as neurosurgeons with doing laparoscopy. So in most centers, actually, the maternal-fetal medicine specialist does most of the repair. The neurosurgeons are trying to help, but we don't have good dexterity. We do a lot of microsurgery, brain tumors, brain aneurysms, but we're not good with working laparoscopes. So the learning curve is very long. So most of the repairs are done by the MFMs. And we love the MFMs, but they don't operate on spinal cords every day like we do. We operate every single day on spinal cord tumors and other operations. So there's a mismatch between the actual expertise and the learning curve to perform the operation. So what is positive about fetoscopy? Less maternal morbidity, smaller scars, and up to 50% can deliver vaginally. Cons, longer operative time, higher rupture membrane risk, and technical complexity. Up to today, in the United States and worldwide, fetoscopic repair is considered experimental. And in North America, everybody, when they consent a mother to go through fetoscopy, they make sure that they tell her, this was not studied in a prospective randomized fashion. This is experimental as we speak today, until a prospective randomized study will prove it. But we have to pay respects to the people who developed the field. This group from Brazil, from Sao Paulo, I had the pleasure to visit them in the past. Here you can see pictures from the early cases showing this is the myelomeningocele, or the spinal cord placode. They do cutting around the spinal cord, and they put a patch, cellulose patch. Do you see it here? And then this is the patch over the placode, then they close the skin. No dural closure, no tubularization or reneuralization of spinal cord placode, like I showed you in the earlier talk, and the goal is skin closure. And what happens is that in many of those cases, hindbrain herniation reversal will happen. Then I get to deal with them after birth because of scarring and tethering between the spinal cord placode and the patch. And this is an illustrative guide for fetoscopy. Again, this is at the programs where they do the exteriorization of the uterus. Uterus is exteriorized, they map the placenta, 2 or 3 trocars, then they do the closure, typically in 1 or 2 layers. And the techniques continuing to improve. I can tell you, the colleagues who do fetoscopy are doing wonderful work, continuing, working extremely hard, working in animal models, working with robotics, trying to improve it. The problem is, we're not anywhere close to what I showed you earlier today with how with using the open microsurgery, we're able to reconstruct the neural tube defects, which leads to long-term impact. This slide actually is very important because it compares standard of postnatal repair, open fetus surgery from moms, percutaneous fetoscopy, 2 centers in Germany and Brazil, and open fetoscopy. You see the outcomes eventually early on are actually very similar. And that's why people get excited about fetoscopy. The problem is we do not have long-term data with fetoscopy. Clearly, for the treatment of hydrocephalus, the numbers are the same. Why? Because we're actually achieving what we want, reversal of the hindbrain herniation, but locally, at the site of the repair, now we have lots of scarring and development of tethering of the spinal cord. Dehiscence is similar, vaginal birth. This center in Germany, 0%, in Brazil, 22%. Open fetoscopy, they talk about up to 50%. Gestation age at surgery with open, 34, with fetoscopy, 36, but with percutaneous around 32 weeks, so less than mom's trial. Rupture membranes, extremely high. You can see here those 2 centers for percutaneous fetoscopy. Rupture membranes in this center, 80%. This one, 67%. So when we look at overall early outcomes for the neonate, I think they're very comparable, although we do not have long-term data. But the long-term outcomes related to the technique complications, tethering of the spinal cord, and long-term outcomes, we'll talk about it in a minute. So we always compare 3 things: fetal, maternal, and neonatal, and then pediatric outcomes long-term. So both can reduce hindbrain herniation. Why? Because we're achieving what we want to achieve, which is stop this CSF leak. Shunt dependence, take more or less between 30 to 40%. Motor function, comparable for now, but we don't have long-term data about the outcomes with ambulation long-term. Maternal, with the open, you have a high risk of uterine rupture, obviously. I haven't seen it in years. And you have to do cesarean always. And with fetoscopy, they talk about less maternal risk. With obstetric outcomes, with open, you can have early delivery. But as I showed you earlier in the last talk, at busy centers, the outcomes are actually great. 60% of our mothers are making it for an elective cesarean section at 37 weeks. And with fetoscopy, you have higher rupture of membranes. When you compare fetoscopy to mom's trial, clearly you have higher, you have reduced maternal morbidity with similar early neurological deficits. And I'm very careful to say early because we don't have long-term data. Question is, people who are doing fetoscopy, they're publishing good outcomes. The problem is they're cherry picking. زي ما بيحكوا بنقوا الحالات. Okay, so الحالات اللي they're publishing the outcomes for fetoscopy, they are hand-picked, they're cherry-picked because they don't want to do the very complex. Like this case went to one of the centers in the United States as a very complex giant myelomeningocele, was referred for fetoscopy. A very experienced fetoscopic team said, no, we're not touching it. They came back to us in Orlando. We completed a very successful repair. And I love that they did not operate fetoscopically on this giant lesion. You can see the spinal cord here is paper thin. You can look at the MRI, how the sac is huge with severe hindbrain herniation. They didn't put their hands in it. They ended up coming to us to do the open repair. So when you publish about good outcomes from fetoscopy, unless you're part of a prospective randomized trial, what you're showing me are hand-picked, cherry-picked cases. Similar, this is another case. How about, we have to remember that 1/3 of open neural tube defects are not the beautiful myelomeningoceles I showed you earlier, but the myeloschises. Like those are extremely complex wide defects. You can see here, this is a spinal cord. All this around it is exposed lumbar fascia. There's no skin. What does that mean? That means in those cases, like I showed you in the last talk, we have to do microsurgical reconstruction, we have to use skin grafts, and we're achieving excellent outcomes. Why? Because we're doing it open. Those cases that are not doing them, many centers fetoscopically, they get sent to us to do them open. Again, cherry picking and hand picking the best outcomes for fetoscopy. Does this deliver the fair message to the MFM community worldwide? I don't believe it would be fair unless there's a prospective randomized study similar to MOMS. And earlier we talked about the multi-layered microsurgical reconstruction. We talked about in the last talk about reconstruction of the placode by microsurgical reneuralization, retubularization, then closing the dura, then closing the skin. Can we achieve a multi-layered, similar, meticulous closure with 3-layer closure and reduce the rates of tethering in the future? We're not there yet. Like in doing this sharp microdissection surrounding the placode, work with 1 millimeter instruments, still, even with robotics, we still have a long way to go. Let's talk about tethering. Does the technique matter? All of you do excellent job with the mothers, with the babies after birth, then they become my problem and Dr. Saad's problem. They're our patients for the next 18 or 21 years, taking care of their spine bifida complications. As early as 2008, at CHOP in Philadelphia, papers started coming out about the high risk of tethering of the spinal cord after fetus surgery, including the development of inclusion cysts called dermoid or epidermoid. So what happens when we go for fetus surgery, the clock is ticking, we have to move fast, we're doing sharp dissection around spinal cord placode. Even with the microscope, some skin cells, epidermal skin cells, will get buried, tendinophin, inside the fecal sac, and then we do the dura closure. What happens a few years later, that those skin cells, they develop what we call inclusion cysts, like dermoid or epidermoid. Then we end up dealing with them surgically. So this paper in 2008, the Danzer paper, was a red flag paper, alarming us that those patients, it's not about how they look like when they're born. You have to follow them long term, because they can be walking at the age of 3, then at the age of 7 or 8, they can be in a wheelchair. If they're tethering of the spinal cord, you are not managing it appropriately. So here you can see that 30% of the patients in Philadelphia who had fetus surgery, they developed tethering of the spinal cord requiring surgery, and 60% of those, they had inclusion cyst. Then we started to look at papers. Which patch is we use for the repairs? Nobody knows. Nobody can tell you. We're all biased. Those are some of my own patients, but from 15 years ago. This is a baby who had fetal surgery, was always had an L3 function since birth, then started developing hollow cord serrings and decline in ambulation at the age of 2.5 years. You do the MRI, you see the tethering here, and you can see huge serrings inside the spinal cord. When I went to operate, it was a nightmare. You can see here severe scarring between the spinal cord and the dura. How about this one? 3-year-old, she had an L3 lesion. I did detethering at the age of 3 years. She declined from walking with a walker into a wheelchair, and the physical therapist was the concerned one. When we did the MRI, we saw this mass, and this mass is the inclusion cyst. And again, those are the outcomes you do not see in obstetric or maternal-fetal medicine papers or conferences, but those are the ones you see them in neurosurgical conferences. Those are the long-term outcomes. And look how this is a nightmare for any surgeon. Huge mass, epidermoid at the terminal spinal cord. Then we started looking at our data. After the MOMS trial, I was in St. Louis. We did 60 repairs. 9 of them, 15% developed tethering. I was happy with that. Why? Because the CHOP Philadelphia group was 30%. And post-birth CSF leaks were 8%. Now, we're close to 60 cases in Orlando. Our tethering rate dropped down to below 10%, and our CSF leak after birth dropped to below 5%. Why are we seeing this improvement? Lower CSF leaks, lower tethering, lower inclusion cysts, because we're improving the technique. And when we looked at our data, this is about to get published, they found that the tubularization of the spinal cord placoid, we showed you earlier, can reduce the rates of tethering. How about MRI?
2 minutes, Dr. Samer.
Thank you. This is an MRI, open fetus surgery. This is one of my patients. You can see CSF surrounding the spinal cord placoid beautifully. And this is one of the fetoscopic repairs, extreme tethering of the cord. Then very proud of the programs that started publishing about fetoscopic outcomes. This is a program in Istanbul. In Turkey, there's one program in Istanbul doing fetoscopic repairs. I'm so proud of them. They started publishing bad outcomes related to tethering. But some programs like a CHOP and others are improving the techniques and doing a wonderful job trying to do 2-layer closure and trying to achieve even watertight closure. We have to respect those programs, but we're not there yet. So, to summarize, what is fetoscopy? It is the future. We're not there yet. The issue is not coverage. The issue is maintaining long-term pediatric outcomes. And one recent paper looked at 300 cases, and we're seeing really improved outcomes. But at the end of the day, we do not have, based on systematic reviews, we do not have comparable outcomes because one of them prospective randomized, the other one is all retrospective. We're getting smaller and smaller in our hysterotomies, which means we hope potentially we can achieve vaginal delivery one day as our hysterotomy is getting smaller and smaller and potentially can allow vaginal delivery. But nothing better than tracking the outcomes prospectively like we do with the North American Fetal Therapy Network. Some programs start, like the one in Leuven, Belgium, started developing training models for fetoscopy with robotics, and this is important. But at the end of the day, why we're doing this? We're doing it for the children. We need to track their outcomes long term. We need to work as a team with our colleagues from other specialties, neonatology, neurology, neurosurgery, rehabilitation, maternal-fetal medicine. We all work as a team to get the outcomes possible. So in summary, open repair has advantages and disadvantages, and fetoscopic repair, we talked about them. What is the future? We need to standardize which fetoscopic techniques are better. There could be a hybrid between laparotomy and fetoscopy. We need to start bioengineering some maybe stem cell patches that can help with the closure, and we need to have long-term developmental outcomes. And thank you so much.
Thank you, Dr. Samer, very much. Actually, we have two place for 2 questions. Any question? دكتور عبير تفضل.
دكتور انت عم تحكي عمالي بفكر how can we reverse sacral nerve injury for these cases? I know they're done a bit late, so that's why it's already, the damage is there. And whatever you do, you improve the movement and you prevent the shunting. But still we have a bladder and stool, loss of control over them. So what's the idea? Can we do it earlier? What can be done for these cases? I'm just, doing, brainstorming for
Sure.
myself. Did you get my idea?
100%. Dr. Arnab, this is an excellent point. So let's talk about why some patients can walk and some of them cannot. We all believe the amniotic fluid is a neurotoxic environment. All the animal studies have shown if you cover the spinal cord early, you'll have better motor function. So what is the amniotic fluid? Amniotic fluid is urine and debris from the skin, from the baby, and it's considered neurotoxic. And all studies have proved that protection or coverage of the spinal cord can improve the motor function. When it comes to bladder and bowel dysfunction, it's not only about protection of the sacral nerve roots or are they exposed to the amniotic fluid or not. There's something called stretch injury, and we see it mostly in myelomeningocele. Let me give you an example. Club feet, you never see it in myeloschisis. You only see it in myelomeningocele, okay? And this data just came out in the last 3 or 4 years, came out from CHOP. They did animal studies, and microscopically, when you have a myelomeningocele, all those lumbosacral nerve roots are stretched in the sac, and this stretch injury in the myelomeningocele leads to the injury to the nerve and leads to the clubbing of the feet. With myeloschisis, there's no stretch injury. All the nerves are in the thecal sac, so you never see club feet with myeloschisis. So unfortunately, when we talk about a lumbosacral nerve injury, all the evidence we have right now is behind coverage. Cover it as early as you can, and there's nothing you can do about the stretch injury. Now, you asked about why not we do it earlier. Well, I showed you in the last talk, all the data has shown that when we used to do the fetus surgery under 23 weeks of gestation, we had higher preterm labor, higher prematurity, and it was a nightmare. So now most fetus surgery centers, we push the fetus surgery around 25 weeks. Even when a referral comes to us in our center at 19, 20 weeks, we do the surgery around 24, 25 weeks because it is safer profile for both the mother and the fetus. So there's any approach you do earlier or later, each has positives and negatives. Thank you.
Dr. Maher?
Thank you, Dr. Samer. Do you know in Jordan, I'm sure you're aware of the situation when it comes to spina bifida. One, late diagnosis. Two, we don't have fetal surgery. Three, they are referred to tertiary centers. For example, at King Hussein Medical Center, where I used to work till recently, we had lots of cases. Okay, either we diagnose them late or referred late. Some of them, if they are diagnosed early, they end up with a termination. And the patients who continue with the pregnancy will be admitted to the neonatal unit. And for some strange reason, there is some reluctancy on doing surgery on those patients. So it is a big dilemma for obstetricians and the family. And then some of them, observational thing is that they end up with sepsis. And sadly, we lose them before they have the surgery. So I'd like to have your comment on this. And the other point is, are you still doing surgery post-delivery? And are there any randomized control studies comparing surgery in utero compared to after delivery? Thank you.
Thank you, Dr. Maita. So yes, absolutely. I'm doing postnatal repairs nowadays, but almost all of them for the cases who did not qualify for the fetal surgery, who met inclusion criteria. If the cervical length is low, if the amniocentesis showed microdeletions ruled out by the genetics, or in myeloschisis cases when the kyphotic angle is more than 30 degrees, or if the mother had a history preterm labor in the past. So the mothers who have meet exclusion criteria are excluded, or the fetus has other anomalies beyond CNS. They get excluded, so we operate on them postnatally. But right now in our practice, 70 to 80% of all the cases referred are done in utero. But we still do some cases postnatally. But the bigger question is, if I may share with you, Once we extend an offer to a family that they qualify for fetus surgery, what's the acceptance rate? 95%, which is a change in the culture. Let's go back to this first question. So, as I mentioned earlier, we have been involved so far with 12 countries. وبالعالم العربي هون في دبي. But we've done it in 4 continents. And each country has the same problem: early detection, early termination of pregnancy, and lack of comprehensive discussion at the time of counseling. And in all countries where fetal surgery programs now are successful, in all of them, termination rates of pregnancy are lower. So what's happening is that in most countries, when a diagnosis of spina bifida is made, the termination of pregnancy discussion is done before a neurosurgeon or anyone involved in postnatal management of spina bifida gets to even talk to the family. I can tell you, I had at least 50 mothers who came to us for consultation for fetus surgery, and the termination of pregnancy was scheduled next day or next week. And they came to us just to talk. And I can tell you they all or most of them canceled the termination. So once the mothers sit down and they talk to a team and they look at the outcomes and you discuss with them the good, bad, and the ugly, they will think about it, and the conversation cannot be the same for an L1 or L2 myelomeningocele compared to S1 myelomeningocele. I can tell you, when I sit down with a mother of a fetus with an S1 or S2 myelomeningocele, I tell her, let's not do fetus surgery, because I know your baby's going to have a better outcome at like an S2 lesion. An L1 is going to be in a wheelchair and die from sepsis before the age of 10. You cannot have the same conversation between those two families regarding termination of pregnancy. So the way to fix it, number one, is here. We're here today. This room is full of experts in OB/GYN and fetal medicine. If 10% of you in this room leave today convinced that there's science behind this, and you start referring cases to some in the room who are interested in potential fetus surgery, this is how you started, by الوعي, التوعية. People know that this is not magic, this is not experimental, this is science, proven outcomes, and early detection. لما يشوفوا حالة بالعيادة 19 or 20 or 21 or 22 weeks with spina bifida, على الأقل text message, is this a candidate or not? And this is how it gets started. Screening for the first case. So the early detection, early referral, comprehensive multidisciplinary discussion and counseling with the families is the way to go. And once all that happens, rates of termination will drop and fetal surgery programs will develop. And this has been proven all over the world right now. Inshallah, we will see it in Amman in the future. Inshallah.
Dr. Ala, last question, بس دكتور علاء لأنه زمان.
Thank you very much. It's very interesting. And I think it could be applied in many centers.
Sir.
Provided that you prove them, or your team of the maternal-fetal will come with you and just decide clearly what is the trip after doing the surgery. What's the mother? Is it going to be in intensive care? Is it going to be carried out in a hospital for a long time?
Certainly.
And this will put the budget. So this is extremely important. Do they have the NICU or do you have the prematurity that can care this baby? And that's Dr. Maher have addressed the point of sepsis. So before doing this surgery, you should have the full program. Absolutely. I mean, the obstetrician and the nursing and the place which is going to be admitted, because it needs very careful attention until the end of pregnancy. So adding this to the budget. So this is an important point. Let me say something about the size of the meningocele. Yes. So it is, you have just mentioned, is it lumbar or lumbosacral? This is totally different. If it is sacral S2 or S3, then we have only problems mostly with the micturition and defecation. The motor is minimal. That's why the surgery would be nice. That's why I wanted in the paper to say which the size is extremely important, because success post-term changes is totally different. We see a lot of lumbar 4, lumbar 5, and sacral, and we see just sacral. If the results are saying that good motor or good function, they didn't mention the size of the meningeal seal. This is extremely important. And he have mentioned tethering. I know that all the obstetrician doing ultrasound know what's meant by tethering. When you see the spinal cord with the meningomyelocele, the spinal cord is going out with a defect. This is tethering, and this is one of the signs. So, as you have mentioned clearly, in the fetoscopy, he cannot treat tethering. If it is already seen by ultrasound, then he is going to put the patch without dissection. And that's, you are going to face the problem of tethering. Tethering means that you have create an adhesion between the spinal cord and the defect, and later on it will show some affection on the motor. It will not give you a success. I think this is my comments on this, and you can elaborate if you want to have it clear.
For the sake of time, I want to thank you, Professor Ibrashi, for the valuable comments. Absolutely, it's extremely important to develop the protocol. And any one of you in this room, if you want the fetus surgery protocol, we'll share it with you. We have shared it all around the world. This protocol is extremely important for any program to develop, adopt it. Each one in the program, they have plan B and C and D for any potential intraoperative failure, post-operative management, tocolytic agents, the epidural, how many days in the hospital. In general, the mothers stay in the hospital for only 4 days, including 2 days in the women's ICU. You cannot do the operation unless you have a nearby neonatal ICU. And I agree with all the comments you mentioned. Now, in regards to the level of the lesion, below S1, it's excluded. They meet exclusion criteria. We've never operated on a lesion below S1. And S1, as you know, does the plantar and dorsiflexion. So it's down to S1, we consider. Below S1, we exclude them. And follow-up studies after the MOMS trial stratified outcomes based on level, and there are more publications that started looking now at the patients who had MOMS trial 15 years ago. Did the level matter? And we have more papers now looking into it. Thank you.
Thank you, Dr. Samer.
Next speaker, Dr. Lisa Story. She's a senior lecturer at King's College Hospital, and she is senior lecturer at that hospital. Her research focus on MRI for fetus. Please, Doctor.
Thank you very much again. It's again an absolute pleasure to be here, and I'm going to have a little bit of a change of tact for this last lecture. And I'm going to talk about fetal MRI and its evolution from structure to function. So fetal MRI isn't a new concept. Actually, the first fetal MRI actually took place in the 1980s, but it was really in the 1990s that it became part of standard clinical practice. So initially, when it was introduced, as we heard earlier, it was really primarily for looking at fetal brain lesions. But now it's far more widespread than that, looking at certain abdominal and thoracic pathologies. Certainly a number of randomized controlled trials have taken place. The Meridian study, which was performed out of Sheffield in the UK, showed that actually MRI can provide additional information to ultrasound. And sometimes when they did that study was potentially more accurate in getting the final diagnosis. I think it was correct in about 90% of cases compared to just under 70 with ultrasound. In addition, it's been used to look at thoracic lesions. So another study found that actually the whole course of management changed in 8% of cases when they were looking at fetal lung lesions. So that's all very exciting, but it's really in the research capacity that that advances are happening rapidly. And that's partly due to the fact that we can now correct for fetal motion, which allows running of more functional sequences so that we can look at functional properties of tissue and its microstructure as well. So this is just a very brief recap of physics from school if people are a little bit rusty, but human tissue is comprised of water molecules, and water molecules have an inherent spin to them. They behave like little magnets. So if you're just walking around in everyday life, all of those spins are in completely random orientations. But when you walk into the main magnetic field of an MRI scanner, all of those spins align with the magnetic field because that's the lowest energy state. You then apply a radio frequency pulse, which tips those spins into the transverse plane. And it's as they relax back to their original low energy state that you can basically harness that signal to generate your MRI image. So obviously that doesn't involve any ionizing radiation, which makes it quite attractive when you're looking at the anatomy of the fetus. So the tissue returns to its original resting state via a combination of T1 and T2 relaxation. So T1 is the time required to regain longitudinal magnetization, and T2 is the transverse relaxation time. So you can basically harness these properties to generate your images. So on the left here, you can see a T2 weighted image. So there the fluid is bright, and that's very good for anatomical assessment. And on the right-hand side is a T1 weighted image. The fluid's dark. That's much more sensitive to motion, but it can potentially provide additional information, for example, about hemorrhage. But it is very motion sensitive. So the other question pregnant women are always worried about is safety. And yes, there's no ionizing radiation, but there are still risks. Probably the main risk is from the static magnetic field. So that's why we ask women who are having an MRI scan if they have any metallic implants, if they've ever worked with metal in the past. And we also make sure the MR environment is safe as well. So this is what happens if you don't make your MR environment safe. And you can imagine that actually, if you're between that and the projectile, it's not going to end very well for you. But in addition, there's other issues. So potentially there's thermal risks to MRI, that you get heating. But they've done lots of studies that show actually the heat deposition is away from the maternal abdomen. And actually, we've done studies where we've looked at changes in temperature of the mother, and it doesn't change by more than a degree. And bearing in mind the fetal temperature is about a degree higher, it's safe. And then the last thing that everyone who's ever had an MRI scan knows, it's incredibly noisy. We can give ear protection to the mothers, we play them some music, and actually the fetal tissue, the noise is attenuated by the maternal tissue. So they've done some really bizarre experiments in male volunteers where they got them to swallow microphones, and it is an attenuation of approximately 30 decibels. But the fact I like more than anything is actually the noise you get from an MRI scanner is very comparable to that of a music concert, and pregnant women still go to those. So I think that's another reason why it's okay. But also that's been confirmed with clinical studies too. So they've had MRI-compatible CTG machines, and they don't find any change in the fetal heart rate during the scan. And they've also followed up a cohort of children who were exposed to MRI in the first trimester of pregnancy to the age of 3. It's a big Canadian study of thousands of women, and there's no differences in outcomes, even with hearing. So, as we heard earlier, there are lots of clinical applications. Particularly now, fetal neurosonography is very good, but it can help with other diagnoses where ultrasound potentially struggles a little bit. Ventricular megaly we heard about earlier, but we've had quite a number of cases of tuberous sclerosis where you can see in the top image does this work? Yeah. You can see these kind of areas of abnormal signal intensity. Ooh, where are we there? Here and here. And then the middle picture is a case of agenesis of the corpus callosum, which potentially you can pick up on neurosonography as well. And there's a large endohemispheric cyst there. And in the bottom picture, you can see an encephalocele. Outside of the CNS, you've got, it's potentially quite useful in congenital diaphragmatic hernia. So it can really characterize the exact position of your abdominal organs. So that can potentially help to prognosticate. And it's also good at distinguishing CPAP from bronchopulmonary sequestration. Now, I do quite a lot of work in pre-prom and second trimester pre-prom, and certainly for looking at lung volumes, it's very good in identifying pulmonary hyperplasia because it has a much larger field of view than ultrasound. Then in the renal tract, this is just a picture here, T1 weighted images. You can see the first picture, there's renal pelvic dilatation and multicystic kidney. The second image there, you can actually see narrowing of the urethra. And the third picture is just to show that this is a male fetus. And it's a case of posterior urethral valves. Again, we heard earlier placenta accreta. So ultrasound's actually really good for diagnosing placenta accreta. But the conditions where it potentially gives you additional information is where you have a posterior placenta and when you're trying to characterize the depth of invasion and involvement of other structures. But what I really want to talk about is what the advances are going to be in the future. And it is a rapidly evolving field, particularly over the last 10 years or so. Because not only can we now look at the anatomy of the fetus, the fact that we can now correct for motion means that we can get really accurate volumes of various fetal structures. And it also allows us to run the more functional sequences. So spectroscopy is basically a way where you can identify the chemical composition of tissue. T2-star relaxometry helps you look at tissue perfusion and is potentially a marker of functional activity. And then diffusion imaging, although it's used outside fetal imaging a lot, it's very motion sensitive. But the fact we can correct for motion now means we can get insight into tissue microstructure as well. So just starting off with the anatomical and volumetric reconstructions. So we saw a cine earlier, but this is another one. Basically, you can see that the baby's moving very unpredictably. We can ask the mother to lie still, but there's also motion as well coming from blood flowing in the abdominal aorta, bowel peristalsis, and maternal respiration. So we can overcome that motion by a number of ways. So firstly, in our acquisition, what we do is we do lots of very quick sequences in multiple orthogonal planes. So we're oversampling the area that we're looking at. So if you look at the brain, each one of those turquoise slices is acquired in less than a second, and then you can realign, you can cover the whole brain in less than 20 seconds. So then what we do is we take all of those oversampled data points and we realign them in a common coordinate space. So it's a technique called slice to volume reconstruction. So you can see the original data sets here. So this stack was acquired just off the axial plane. And you can see if you look at the two other planes in that stack, it's really motion corrupted because you get interslice motion. Likewise, this one's acquired in the sagittal. Here we've got in the coronal. But when you apply the SVR, these are the kind of images that you're getting. So not only does it enhance the actual quality of the images, but you can realign them to anatomical reporting planes as well. And I have a postdoc who works in my group, Alina Us. She's an amazing computer scientist. And what she has basically done is using AI to automatically segment out brain regions and then automatically report them on centile charts as well. So you can apply a similar technique to looking at the thorax. It's particularly good for looking at the lungs. The only slight difference you have to do is a very slight modification of SVR, because if you think about it, the skull's a really rigid structure, whereas the abdomen and the thorax have quite unpredictable motion in lots of different directions. But again, you can get very accurate volumes. So we've started now looking at the lungs in more detail, so we can actually segment out the various lobes of the lung. We've started doing it in congenital diaphragmatic hernia, and we've developed the normal ranges, but that's part of an ongoing study called NANO. And I've been using these techniques in my research fellowship to look at the cohort of fetuses that deliver prior to 32 weeks. So I guess, as I alluded to this morning, we don't really know what causes women to go into labour preterm, but we think that infection and inflammation is involved, particularly at the early gestations. We also know from animal models that potentially inflammatory cytokines affect brain and lung development, which are the end organs that are susceptible in preterm birth. But traditionally, it was always thought that the insults that occur are happening in the postnatal period. But actually, you can make quite a good hypothesis that the processes that are causing the women to go into labour in the first place are actually affecting how that baby's developing while still in utero. And that's certainly what we found. There's smaller cortical volumes, smaller CSF volumes, and smaller lung volumes in fetuses that subsequently deliver preterm. And that's important. You know, I talked about the magnesium story earlier today, but actually if we can show that changes are happening in fetal development in the weeks, days, months even, prior to preterm birth, then maybe we're not timing that magnesium sulfate in the correct window. But again, watch this space. It's been applied to other cohorts as well. These are just two as an example. So ventricular megaly, it looks like there's cortical overgrowth that you can detect in utero with it. And in Down syndrome, if you're looking at total brain volume, it's reduced in Down syndrome fetuses, and particularly those who have concomitant congenital heart disease as well. So the next technique I'm going to talk about is a more functional sequence, and that's T2 star relaxometry. So this basically harnesses the fact that oxygenated and deoxygenated hemoglobin behave very differently when you put them in a paramagnetic field. So what you do is you basically acquire your acquire your data at different echo times. So this is an example from the placenta, and then you generate a map. So this is a T2 star map of the placenta. You can see that the yellow areas represent indirectly high oxygen content, and the darker areas are low oxygen content. So if we then look at a normal placenta across development, you can see the top line is a healthy second trimester placenta. It's nice and well perfused. By the time you get to the third trimester, you're getting distinct lobules forming, but it's actually much darker, so the perfusion's decreasing. And if you compare that with a preeclamptic or a growth-restricted placenta in that bottom line, you can see very visually how different it is, and you can measure that quantitatively as well. So again, I've applied it to the brains of those growth-restricted fetuses, and again, we're seeing a reduction in global perfusion. And we've also used it to characterize lung development as well. So this is some work from one of my PhD students, Carla, and she looked at normal lung development using T2 star relaxometry across gestation. So you can see here, this is a 22-week fetus, it's quite dark, and then you can see the change as you move through gestation to 38 weeks when it's much more perfused, and that's likely to represent increasing metabolic activity associated with pulmonary development in utero. So then we've started to look at some pathological cohorts. So one of the ones, this is just retrospective data to start with. We looked at fetuses with congenital diaphragmatic hernia. And what we actually found was that when we looked at the contralateral lung, low mean T2 star values actually prognosticated in terms of survival, where the volume didn't alone. So that's small numbers, but we have a large prospective study that's going at the moment. And we're also looking at other groups like second trimester pre-prom. So again, we can prognosticate and care plan for that group. So the next technique is diffusion MRI. So as I mentioned before, it is already used in standard clinical practice in adult and pediatric medicine. But diffusion basically harnesses how water moves in biological tissues. So if you have a free expanse of water, those molecules are moving completely randomly, like Brownian motion. But when you start to introduce cellular complexity, the pattern of that movement changes and that the diffusion's hindered. So you can measure that quantitatively using parameters like the apparent diffusion coefficient, or ADC, and fractional anisotropy, which is more directional. So certainly in the neonatal brain, ADC and FA values predict poor neurodevelopmental outcomes. In the placenta, maybe it gives us insight into villus tree development. And in the lung, maybe it's telling us about how those alveoli are, which again is probably a more functional assessment than just looking at size alone. Again, applied to that preterm cohort less than 32 weeks, and we are seeing significant differences, significant differences there. And the final technique that I'm just going to cover is MR spectroscopy. So instead of generating an image from your data, you can also generate a profile of the metabolic components of that tissue. And that's due to the fact that when protons are incorporated in different tissues, how they return to their resting state is basically changes. It's a process called chemical shift. And it's very dependent on the local environment. So using the technique, you can see a number of different things. You can see N-acetyl aspartate, that's a neuronal marker, and it's also a marker of mitochondrial function. You can see choline, which has a role in cell membrane formation. Creatine has a role in energy metabolism. Myoinositol, which has a number of functions, it's an osmolyte, has a role in cellular detoxification. And lactate, which is the end product of anaerobic glycolysis. And a number of different groups have looked at using proton magnetic resonance spectroscopy in the fetal brain, and it's shown that there are lower NAA levels, which potentially is consistent with animal studies that show that the mitochondria are abnormal in this cohort. The last thing I really wanted to talk about, though, was low field imaging. So most of the MRIs that we do in clinical practice are actually at 1.5 Tesla field strength. In the research setting, we use diffusion a little bit more. It has enhanced signal to noise, and it's very good for diffusion sequences as well. But actually, there's been a bit of resurgence in low field imaging. So now we can actually process our data and get really good clinical images. We are actually able to report from those low field scans. It has a number of inherent advantages to it. So firstly, the actual machines themselves are much lower cost, but they also have a really big bore size. So we've actually scanned women with BMIs over 60 in our low field MRI scanners. And also, it's actually much better for those sequences like T2 star relaxometry. If you're interested in reading about it a bit more, that paper was published in, our paper was published in Radiology in 2024.
2 minutes, please.
That's fine. It's the last slide. So really in conclusion, fetal MRI is a rapidly evolving field, but I think what needs to happen next is to work on post-processing of these sequences. A lot of these post-processing techniques I've described, we're now working with the scanner manufacturers to incorporate them into the scanner software. And actually only then, when you can process the data and give the results in real time, can you do the multi-center studies that are actually required to assess their true clinical utility. So loads of people, I work with a really amazing team, and I'm very grateful to all of them. And if you have any questions, I'd be really happy to take them.
Thank you very much. Any questions, please? Please, Dr. Abuna.
Thank you for a very interesting presentation. So right now, actually, at your unit, I see a lot of it is research. What are your actual indications for asking for an MRI for a patient?
Yeah, so we use them in placenta accreta when it's posterior placenta and we're worried about depth of invasion. We do a lot for fetal brain as well, just because we can. Congenital diaphragmatic hernias all get fetal MRIs, and as we mentioned earlier, when we have large neck masses, it just helps us to plan care. So we cover a large referral area. So, we decide whether they'll need exit procedures and things like that, because they can get good images of the airways.
I have a question for you. Beautiful talk. What about the cardiac MRI? Are these gated ones, or how is the setup and how the Tesla and all that?
Yeah, absolutely. So David Lloyd and Kubrin do a lot of fetal MRI, and that's actually incorporated into their clinical service now. So particularly things like coarctation, they'll decide where they care plan via doing the 3D reconstructions of the heart, and they can look at the major blood vessels. They're definitely their area of expertise more than mine, but they're doing an amazing job at the moment.
The same machine that you use for the lungs and the brain is the same.
Yeah,
You're required to do ECG gating. Is it, I think, built in, right?
Yeah, they do use gating. I think the other thing, most of the clinicals are done on the 1.5 Tesla scanner, but they are actually working it up on the low field 0.55 Tesla as well. So I think the move is to go to the low field, because actually on our neonatal unit, we have a MRI scanner. It used to be a 3 Tesla, but it's now being replaced with a 0.55 T.
And do you sedate, I mean, you and them, do you sedate the mother for this?
No, we don't, because actually now we've got these post-processing techniques, we can actually correct for a lot of the motion that we're getting. And there's a lot of studies that show that actually if you give benzodiazepines to the mothers, potentially if you're looking at the functional sequences, particularly spectroscopy, it can actually affect the results as well. So
nothing to the fetus.
No.
I can see it jumping inside and
yeah.
I'm wondering. Thank you.
دكتور علاء تفضل.
Thank you very much. Continuing to the question of Dr. Amona, you have mentioned what are the most common now doing MRI. But in your presentation, you mentioned that we can differentiate between bronchopulmonary sequestration and CCAM.
No, I mean, you can, undoubtedly with ultrasound, you can find that feeding vessel, but we've had a number of cases where they have been referred for a fetal MRI for some other reason as well, and we have actually changed the diagnosis. So I think it can potentially, in some cases, and you know, the other thing is ultrasound it's fraught with challenges. You know, if the woman's quite large, if the baby's in an unfavorable position, you know, it can sometimes help to overcome some of those issues.
I want to you know that there is no any change in the prognosis or in the outcome between bronchopulmonary or CCAM. Postnatally is going to show.
But I think what we might be able to do in the future, so what they can't do at the moment, so now there's evidence that a proportion of CPAMs actually have malignant change later on. And also, what the neonatologists always say is what would be really helpful to them is to know which of the CPAMs need urgent intervention post-delivery and what don't. So in the future, maybe we'll be able to use these more functional sequences to help tease out those aspects of the care.
The second question is that you mentioned the volumes, but volumes of the lung, volumes of... did you compare the results of the 3D volumes with the MRI and find it's much superior on the 3D?
It's definitely superior. So we know from, for CDH, we know that the lung-to-head ratio prognosticates really well. Like, that's fine. But when you look at the studies for women with second trimester pre-prom, it performs extremely poorly. And that's a group that's really relevant, probably more in the UK than here, because those women are counselled very heavily to terminate currently, because the law in the UK is that we offer termination until 24 weeks. So there was a study called UCOS that looked at the outcomes of women who had pre-prom before 23 weeks, and it actually found that 30% of them are surviving with good outcomes. So women are having to make these really difficult decisions about whether to continue a pregnancy or not, based on very little data. So actually having something that could tell them whether they're in that group that's going to do really poorly or whether they're in the group that might do well would actually help that decision making.
The lung volume, you mean?
The T2 star and the volume too. Because sometimes those second trimester pre-proms, particularly, they're all curled up. You know, it's actually quite difficult to get really good images if there's complete anhydramnios.
Okay, last question, Dr. Abir.
For gadolinium. Yeah, I doubt we'll ever need to use it, actually, because I suspect we can use the amazing computer scientists and all of the other developments to kind of obviate some of those problems.
Thank you.
Thank you, Dr. Lisa. Thank you very much. Our next speaker, Dr. Mona Belgar. She is a professor of obstetrics and gynecology at Cairo University and fetal medicine consultant at Cairo Fetal Medicine Unit. She will talk about screening of chromosomal abnormalities in the second trimester. Dr. Lisa, please.
Thank you for the introduction, and again, thank you, Dr. Abir and Dr. Meher, for the kind invitation. A bit of a change from the previous subjects. With the current practice, it's not supposed to be the main indication for doing a second trimester scan, looking for chromosomal abnormalities or screening the patient for chromosomal abnormalities. What actually the practice now, I think, which has been here for more than 2 decades, is to do the first trimester through measurement of the NT, the nasal bone, tricuspid, and ductus, and doing an anomaly scan and doing screening for preeclampsia. And with the first trimester parameters, we can give a detection or a sensitivity of about 85 to 90% to detect Down syndrome. And then with the introduction of the cell-free DNA or the NIPT, we know that the detection rate for Down syndrome is about 99%. And therefore we have 2 screening methods that have a quite high sensitivity and quite high detection rate. But this is not true life. True life is that many of our patients, they come for the first time at the second trimester scan. If the first trimester scan is provided by the health insurance and is free, of course patients will do it. Some countries it is not, and it's the second trimester scan that is covered. So then they will have their second trimester scan. And now with the very widespread use of the cell-free DNA, many countries are offering cell-free DNA for all the patients, plus or minus the first trimester scan. So why should we still do the second trimester scan? Well, yes, of course we should, because we know that there are certain congenital anomalies that are quite difficult to detect in the first trimester, or the detection rate is less, such as anomalies of the limbs, only 1/3 will be seen, the face 1/3, genitourinary 1/3, and also congenital heart and posterior fossa anomalies. So we still need to do the second trimester scan. And many patients, as I mentioned, especially in countries like Egypt, they present for the first time for a detailed scan at 18 to 24, and the mother is aware that at that time you can suspect if there is a chromosomal abnormalities, and she is worried and she is anxious and asking about it. And of course we should, in addition to having a full anomaly scan, reassure the patient about the chromosomal abnormalities. So is this possible? And what are the second trimester ultrasound markers that we should be looking for? These are the most famous and the most reported: prenasal edema, absent nasal bone, renal pelvis dilatation, ventriculomegaly, nuchal fold thickness, and echogenic foci in the heart. And I could add to this list the short femur and short humerus. One of the recent markers as well is the aberrant right subclavian artery. Professor Ala mentioned it in his talk and described the anatomy and how to find it and how to see it, and that we can see it starting from the first trimester. So these are the common ones that we are used to and are quite experienced in looking at them. Now, which one of those has the highest detection rate if present? This was a meta-analysis published now more than 10 years ago, and it was a collective data of a large number of studies, and it shows that the markers that had the highest positive likelihood ratio are ventriculomegaly, increased nuchal fold, aberrant right subclavian artery, and absent or hypoplastic nasal bone. So these are the markers that when you see, the likelihood is much higher for this baby to have a chromosomal abnormality, most commonly Down, of course. And if it is absent, of course, it gives a good negative likelihood ratio. If we look a bit at the details, the short femur is always a very, very worrying feature for many of the doctors who refer to us fetal medicine specialist cases. And of course, I think the key issue is if this patient has performed a first trimester scan, you have done a proper dating, and you have measured the femur and the humerus in the first trimester, you don't need to worry that much. But in this Danish study, which was done on patients that did have a first trimester scan, this was a very big Danish population, and in this study, it was mainly due to small for gestational age, and it was present in a small number of cases that had trisomy 21, about 16%, and the positive likelihood ratio was about 8.8. Other reasons for this short femur, such as other trisomies, unbalanced autosomal structural abnormalities, were also the reasons, and therefore it is not purely or simply just a Down syndrome. The aberrant right subclavian artery has also been studied a lot, and as I mentioned, the prevalence of aberrant right subclavian artery is quite high. Almost a quarter of the cases with Down syndrome will have it, while the euploid fetuses, it's only 1%. So you should be, I mean, if you are a fetal medicine specialist, you should be train yourself to see the aberrant right subclavian artery, and the likelihood ratio, as I mentioned, was quite high. But more recent studies showed that it is quite rare to be there alone. It will usually be associated with other cardiac abnormalities. So if you find it alone, it's just, you need to have a very good look at the heart, very proper examination of the heart, refer to somebody more experienced in fetal echo, because usually the cases that turn out to be Down will have other cardiac abnormalities. Earlier studies showed that there should be more than one soft marker, so not just one soft marker, to be able to say really that there is an increased risk for Down syndrome. This is a Swedish study over 20 years now, but it was a randomized study. It was a very big study covering the whole of Sweden with more than 40,000 pregnancies, and they randomized the patients, half of the patient doing only the first trimester scan and the other half doing the second trimester scan. And actually, 20 years ago, their ability to diagnose and detect cases was not much different in the first from the second, so it seemed that they did not miss that many cases in the second trimester, which is of course reassuring. Of course, over the last 20 years, things have evolved, machines and our experience, and the main advantage of the first trimester scan was that you had fewer invasive tests, so you were able to diagnose early, the fewer invasive tests were needed. So the issue is, if the patient has performed the first trimester scan and then you see a marker in the second trimester scan, should you be worried? Should you do something further or not? Is there a role for the second trimester scan? Well, most of the cases will be detected in the first trimester with increased nuchal translucency and all the other markers. But in the second trimester, if you don't have any congenital anomalies and you don't and if you don't have any of the soft markers, probably this fetus is normal. And the main marker they were talking about at the time was the increased nuchal fold. The other issue is the anatomy. Because we are able to have a very good look at the anatomy, especially if the person who is performing the ultrasound is an experienced person, you need to concentrate very much on the full anatomical scan of the patient, because we know that a normal anatomy in the second trimester in itself means a marked reduction in the risk of chromosomal abnormalities. And if we are going to perform the second trimester scan, which was previously known as the genetic scan, you should follow the ISWG guidelines, which has now been updated just 3 years ago, and this is their extended list. So you should actually try to look at everything, the details of the brain, the posterior fossa, the ventricles, cerebellum, the face, the orbits, the facial cleft, of course the mouth, and of course the nasal bone, presence of cystic hygroma, look at the chest, the heart, the lungs, and the detailed anatomy of the heart with the outflow tract, check the intact diaphragm, the stomach bubble. So do a full anatomical scan, check the cord insertion, look at all the long bones and measure the femur and the humerus, the hands and the feet. And doing this, we know that certain anomalies are quite famous and quite well known to be associated with chromosomal abnormalities. So we know that facial clefts and holoprosencephaly more associated with trisomy 13. We know that certain anomalies are very famous for Down syndrome, like absent nasal bone, increased nuchal fold thickness, congenital heart, especially AVSD, VSD in the perimembranous VSD, esophageal atresia, duodenal atresia, diaphragmatic hernia. All of these are very much related to trisomy 21, omphalocele, trisomy 18 and 13, cystic hygroma in Turner, and of course small for gestational age. Small babies should always draw your attention that this could be a chromosomal issue. So just a few examples of AVSD, clefts, facial clefts, double bubble sign, absent nasal bone, and another cleft, very clear cleft lip, and cystic hygroma, and another cystic hygroma and holoprosencephaly. I think these are anomalies that are, I mean, even if you're not that experienced, you will be able to detect them in the second trimester scan, and these are the cases that you should refer to a more specialized center and counsel them about the increased risk of chromosomal abnormality and the importance of excluding a trisomy. The issue of choroid plexus cyst and a single umbilical artery. With time, the anomalies or these soft markers that were very famous in the beginning and people were very anxious about them and associated with increased risk with time and with a lot of research, the worry and the anxiety of these minor soft markers is becoming much less, and we have evidence to that. So the recommendations of the Society for Maternal and Fetal Medicine in the USA is that if you have, like the echogenic bowel, if it's just isolated echogenic bowel, don't worry about it. Think about cystic fibrosis or infection such as CMV, and do a third trimester ultrasound for growth groth. If it is an isolated single umbilical artery, don't worry about it, just follow up the fetal growth in the 3rd trimester. If it's an isolated urinary tract dilatation, we assess at 32 weeks just to determine if the patient needs or the baby needs follow-up postnatally. And if it is isolated shortening of the humerus, the femur, or both, you need growth assessment in the 3rd trimester. And they divided the findings or the soft markers based on if the patient had performed an NIPT or a 1st trimester scan or not. Of course, if you have done something like the NIPT, all these soft markers, they become, you don't need to worry too much about them. You don't need to do any other further tests on aneuploidy, especially if the soft marker is an isolated soft marker. So an isolated echogenic focus, isolated bowel, urinary tract dilatation, short humerus, short femur, thickened nuchal fold. You could discuss with the patient the risk of trisomy 21, and if she wants something more invasive, like the amniocentesis. But if the patient has performed something which has a very high sensitivity, like the NIPT, you don't need to worry. The issue is the patients that come to us and they have not performed any early on screening for chromosomal abnormalities. You need to discuss with the patient if she should proceed further with NIPT or the quad screen. There are certain markers that are more indicative of trisomy 21, such as increased nuchal fold or absent nasal bone. In this case, maybe you need to advise for NIPT or an invasive test. And if it is an isolated choroid plexus cyst, you can discuss with the patient, but you probably don't need to do something further. Finally, invasive testing. Of course, the patient should be explained that the invasive testing is we might need to resort to it. It will be 100%, and we will be able to exclude chromosomal abnormalities. She should be reassured that it is a simple procedure. It has around 1% of miscarriage, and it will, of course, give us the diagnosis. But remember that sometimes it is not enough just to do a regular karyotype. You need to do further testing like microarray if you are suspecting something genetic. So my conclusion is that of course, if 1st trimester screening or NIPT has been done, the situation is totally different when you do the 2nd trimester scan and you see any of the soft markers. The situation is different if you see the patient for the first time and you have one of those soft markers. Remember the likelihood ratio of the 4 or 5 markers that have a higher likelihood ratio. Maybe these are the ones that the patient we should worry about, and we should do further testing. Thank you very much.
Okay, thank you, Dr. Muna. We have place for questions. Any question? Dr. Maher.
Thank you. We had a debate yesterday about the 1st trimester scan and the NIPT. I personally believe that if we can afford it, every woman should have 3 scans. One in the 1st trimester, with NIPT, then 2nd trimester when you do your anomaly scan and look for the markers. And then the 3rd trimester is very important as well. Yes. And yesterday we heard that only 20% of units in the UK, they have, I don't know if Lisa wants to come on that as well, they only have a 3rd trimester scan. I mean, the advantage of a 3rd trimester scan is sometimes you can have changes in the kidneys, in the brain, the ventricles, growth, placenta, if somebody missed the accreta or the yes. placenta previa. So I would like to hear your views on that. I mean, do you agree with this argument? And I try to bring my patients, even if the 20-week scan is fine, yes. I'll say sometimes, in rare cases, you might have changes, Dr. Ala maybe will add to that, that you can pick up, because sometimes sure. I had a referral where a normal scan at 20 weeks, but there was a pathology sure. when the patient was scanned at 32 weeks, for example. So I'd like to hear your views on that.
I totally agree. But first of all, it is the recommendation, the most recent recommendation of the ISWG to do a 3rd trimester scan. And I know the Fetal Medicine Foundation is very much with a 3rd trimester scan. But you have the main issue is the financial issue. Patients, if they're going to pay for all of these scans, or even if the insurance is going to pay for it, it means that there is a very big load on the system and on the insurance to pay for these 3 scans. The other issue issue is if we're talking about chromosomal abnormalities and we will detect them in the third trimester, then there's not much to do. The idea of detecting this early is to give a chance to the patient to do whatever invasive test or NIPT to be sure and have the decision if she wants to continue or not the pregnancy, if she is allowed, I mean, depending on the laws in the country. So the idea of doing it earlier, I would love too that this can be applied, and I'm very much a strong advocate of the first trimester scan and of course, if possible, NIPT, but it is a huge financial burden, and in our part of the world, I don't think our patients or our governments can afford this, unfortunately.
Any question? Adi.
Trimester scan, and they are talking all about 36 weeks. It's too late. Why not 32? Why not 33? Everybody is saying
It's
about
the third
36
trimester.
weeks. Third trimester. It's not no. We're talking about heart. We're talking about the brain. Sometimes it comes later. But why 36?
I think
Why
the
not
importance is so that you're prepared. Okay, there is a problem. She's about to deliver very soon. You need to be prepared. Where? And this situation happens in our countries. She's from the countryside. She's from Upper Egypt, very far. At least she's prepared where she will deliver. The team is ready. They know, especially like congenital heart defects. Some of them are discovered for the first time in the third trimester. It happens all the time. And so you are prepared, you know what the baby will need immediately. Will the baby need immediate intervention? Will we need a special team? I mean, you try to minimize the neonatal issues by being prepared. I think this is the main thing.
But the psychology of the mother will not be prepared at 36 weeks that she's refusing
I think
a baby. A too late diagnosis. 32, 33 might be, there is time
but
for her.
definitely better than discovering at the time of delivery that the baby has a facial cleft or has a congenital heart and dies a few hours postnatal and she didn't know. I think a very big part of our neonatal deaths are due to congenital heart, and we don't even discover it. So this is, of course, very important, at least maybe for our statistics and for offering a better management to the patient.
Yeah, yes, earlier is better. Yeah, thank you.
Yeah, okay, thank you very much. Now, coffee break. 15 minutes.